Good morning, good afternoon, everyone, and welcome to our CanVector National Thrombosis Seminars. I'm Dr. Agnes Lee, hematologist in Vancouver, and thank you very much for joining us today. As some of you know already, the CanVector National Thrombosis Seminars is a monthly seminar, and we host this live, but it's also recorded as well, so you can join later or revisit the presentations. We've had some amazing features of international and Canadian experts talking about various thrombosis topics. The seminar is also an approved activity by the Royal College of Physicians and Surgeons of Canada, so you can collect Section 1 points for this. I want to thank our planning committee for helping us to organize, and one of the members from the planning committee will be presenting today. And just a little bit of about today's presentation. So our theme today is looking at thrombosis and thromboprophylaxis in patients with myeloproliferative neoplasms. And we have two outstanding speakers. I am thrilled that we have Dr. Anna Falanga, who's going to be talking to us about thrombosis in the ECR-able negative MPNs, and we have Dr. Miriam Kimpton, who's going to talk about thrombosis and thromboprophylaxis in JAK2 positive MPN patients as well. Because of the timing, we're going to take all the questions and answers at the end of both presentations. So there'll be a 15-minute Q&A period at the end of both presentations. But you can submit questions anytime during the talks using the Q&A function. So not the chat function, but the Q&A that you see at the bottom of your Zoom. And then we will be addressing all of those questions at the very end. So without further ado, I want to introduce Dr. Anna Falanga. Dr. Anna Falanga is a professor of hematology at the University of Milan Bicocca and the chief of a department of immunohematology and transfusion medicine and the Thrombosis and Hemostasis Center at the Hospital Papa Giovanni XXIII in Bergamo, Italy. Dr. Falanga is a world expert in the field of cancer and thrombosis, and she has authored over 300 publications and have been the editor of multiple volumes. She has co-chaired and participated in numerous international clinical practice guidelines, including the Italian Society of Medical Oncology, the American Society of Clinical Oncology, and the European Society of Medical Oncology. She has had a tremendous impact as well in multiple thrombosis and hemostasis societies, including ISTH, EHA, the Italian Society of Thrombosis Hemostasis, and the Italian Society of Hematology. She received the Bach Investigator Award of the ISTH in 2009, and also the very prestigious Harold R. Roberts Medal in 2015 from the SSC of the ISTH. And last but not least, Dr. Falanga is the organizer and host of the international conferences on thrombosis and hemostasis issues in cancer. And she has done this for over 20 years now in beautiful Bergamo, Italy. And sadly, the conference was postponed last year, but she'll be going ahead with this and virtually in April this year. So I strongly encourage all of you to tune in and hear about the latest topics in cancer and thrombosis. Dr. Falanga, thank you very, very much for making the time to present us today. We're very honored to have you. Thank you.
Thank you very much, Dr. Lee, for this very nice introduction and for inviting me to give this introductory talk to the seminar of today by Miriam Kimpton. She will be presenting research on concerning projects on thromboprophylaxis in patients with myeloproliferative disorders. And dear colleagues in the audience, I am very happy to share with you this introductory presentation. May I have the first slide? Okay. So the disclosures, okay.
You should be able to advance.
That's great. Okay. So we talk about BCR-ABL negative myeloproliferative neoplasm, which are, according to the WHO 2016, this MPN include essential thrombocythemia, polycythemia vera, and the primary myelofibrosis with the novel subcategory of prefibrotic early stage myelofibrosis. Thrombotic events are a major cause of morbidity and mortality in these patients, besides transformation into secondary myelofibrosis or acute myeloid leukemia. The spectrum of thrombotic manifestation in these disorders is very, very wide and encompasses all types of different thrombosis, arterial thrombosis, venous thrombosis, particularly at unusual sites like visceral thrombosis and cerebral venous thrombosis, and very typical are microcirculatory disturbances, including erythromelalgia, seizure, migraine, vertigo, and others. The thrombosis, compared to the general population, the rate of arterial and venous thrombosis is increased threefold and tenfold respectively in these diseases, and arterial thrombosis are more frequent than venous thrombosis, accounting for approximately 2/3 of total thrombotic events. Cardiovascular mortality of 1.7% patient per year has been reported in polycythemia vera. Here are reported the cumulative rate of thrombotic events in the follow-up percent patient here in PV, ET, and PMF, both for arterial and venous events. So the life expectancy of patients, particularly with the PV or ET, is strongly affected by the disease-related thrombotic complication. And the management of the disease remains highly dependent on the thrombotic risk of the patient. So the main goal of therapy in both PV and ET is to prevent thrombohemorrhagic complication. This is very, very important in this disease. And therefore, it is important to know the risk factors to calculate the risk level of thrombosis in this patient, in single patients. And the clinical risk factors include the clinical risk factors, which include older age, history of thrombosis, and the cardiovascular risk factors such as obesity, hypertension, smoking, etc., and biological risk factors, among which are the elevated blood cell count, erythrocytosis and hematocrit are a risk factor, leukocytosis. Less important is the role of thrombocytosis, because this has not been found to be an independent predictor of thrombosis in any of the studies, though we can discuss that eventually. Then important biological risk factors is the presence of the gene mutation, the JAK2 V617F mutation, and also in some cases inherited thrombophilia. So the clinical risk factor, the classical risk factor are these two, the older age above 60 and history of thrombosis. These are established predictors of recurrent thrombosis in PV and ET and are the cornerstone for risk stratification. Then we have the cardiovascular risk factors, which are not formally included in several risk assessment score. However, all patients should be managed aggressively for their generic cardiovascular risk factors and advised to stop smoking. As far as the biological risk factors, the role of erythrocytosis and the high hematocrit is well established. The blood hyperviscosity is a major cause of vascular disturbances. As I said, the role of thrombocytosis is more controversial. No data show thrombocytosis as a predictor of thrombosis. Vice versa, the opposite, extreme thrombocytosis predicts for bleeding. The role of leukocytosis has also been found, particularly in essential thrombocythemia and in arterial subgroups. However, it is difficult to establish the cutoff for leukocyte count, and therefore this has not been included in many predictive scores. The others, the gene mutation, it is very convincing and important to mention that the presence of the JAK2 mutation V617F is a thrombosis risk and is now included in the modern ET stratification models. Inherited thrombophilia such as factor V Leiden and prothrombin mutation is higher in MPN with venous thrombosis. So the mechanism of thrombosis in MPN relies particularly in changing in whole blood cells, including endothelial cells, red blood cells, platelets, leukocytes. They become all activated and express more adhesion molecule on their surface, so they are more sticky, and the red blood cells and the other series of blood cells coming from the stem cells carrying the JAK2 mutation appear indeed activated, so they attach to the endothelium, they participate in the generation of thrombin, and also adhere to platelets. Platelets also express their molecules, adhesive protein molecules on the surface, and activate coagulation, release tissue factor microparticles. They also aggregate with the leukocytes and activate the leukocytes to express NETs. And the big leukocytes also are activated and they release their intergranules content with enzymes that activate coagulation, carry tissue factor, express NETs, and can adhere to platelets and to the endothelium. So you can see that easily all these ingredients here can participate in the formation of microthrombi on the surface of endothelial cells and ultimately at the site of the vessel. So in the thrombotic risk classification of PV includes the two major risk factors, mainly age, more than 60, and history of thrombosis. So when both of them are present, we have the high risk category. If none of them is present, is the low risk. And of course, the potential danger of cytoreductive therapy to prevent thrombotic complication is justified only in high-risk patients. Then additional factors are cardiovascular risk factors, as I said, and the leukocytosis, but they are not directly included in the risk classification and the decision-making as far as therapeutic options. So the thrombotic risk in essential thrombocythemia first were based on this IPSET thrombosis score, which included age above 60, cardiovascular risk factor, thrombosis history, and the JAK2 mutation. Less than 2 points is a low risk, 2 intermediate risk, and more than 2 qualifies for high risk. Shortly after that, this revised IPSET thrombosis score has been published, and in a new category, the very low risk is introduced, which distinguishes on the basis of the presence or not of the JAK2 mutation, the very low from the low categories. The very low is age less than 60, no thrombosis, and JAK2 wild type. When we have the presence of the JAK2 mutated, we go to the low categories, and then we have the intermediate and high. But as you can see, the JAK2 mutation in the classification of the risk in essential thrombocythemia is very important. Also, in the classification of pre-PMF, this is the stratification according to standard risk factors. This is on the basis of the IPSET thrombosis and revised IPSET thrombosis. And you can see that the IPSET score can be used also for the thrombosis risk stratification in this patient and help to individualize the management in order to reduce the risk of the cardiovascular risk. So prevention of thrombotic complication in MPN is extremely important. Of course, these are some guidance that the group of experts have published in the recent years. In essential thrombocythemia, the prevention of thrombosis in the very low risk categories, the only observation if no cardiovascular risk factors are present, and if there are these risk factors, consider once daily aspirin. this is the recommendation, at least the suggestion. The low risk is, if no risk cardiovascular risk factor, once daily aspirin. If there are risk factors, consider twice daily aspirin. In the intermediate risk, without cardiovascular risk factors, so once daily aspirin, but if there are risk factors, in this case, start side reduction with hydroxyurea, and once daily aspirin. And then the high risk, of course, we start with cytoreduction. And if intolerant, resistant to hydroxyurea, consider second line drugs like anagrelide, although this is the first line approved in US and Japan. Interferon in young patient, abuse wolfan in older patient. If arterial thrombosis history, consider twice daily aspirin. If venous thrombosis, consider anticoagulation. And I think that, can you go back to slides, please? Oh, okay, probably it's missing. It's okay, but it was just for, please go ahead, I'm sorry. Okay. And for primary myelofibrosis observation, if no previous thrombosis, once daily aspirin, if there is no previous thrombosis or bleeding, but there are risk factors, cardiovascular risk factors. And again, previous thrombosis, if arterial, once daily aspirin, if venous anticoagulation, if thrombosis or leukocytosis, cytoreduction with hydroxyurea. And if previous bleeding, avoid aspirin, and if thrombosis or leukocytosis, cytoreduction with hydroxyurea. But in primary myelofibrosis, there are also other specific therapies to be considered, including bone marrow transplantation. The recommendation for PV is missing, but in any case, for all patients who are for all patients with the phlebotomy and primary thromboprophylaxis with aspirin is recommended. And if they are low risk, the no cytoreduction is recommended, but with the high risk, of course, cytoreduction plus twice daily aspirin is suggested. The next. Okay, so as far as treatment in MPN, the rate of recurrent thrombosis is higher than in the general population, but also bleeding is higher compared to the general population. So the decision on antithrombotic treatment must always take into consideration the greater bleeding potential of these patients. The recurrence of arterial event, of course, is then important. The aspirin administration, maybe twice daily, or clopidogrel. Correction of the cardiovascular risk factor is mandatory. And in patients at high risk of arterial events, treatment with the wide spectrum cytoreductive agents such as hydroxyurea, rather than a narrow spectrum strategies such as anagrelide or phlebotomy, should be considered in order to decrease all the types of circulating blood cells. The management of VTE does not differ from the treatment of VTE in the general population, and in the acute phase, low molecular weight or fondaparinux is suggested, and overlap with vitamin K antagonist aiming to target of INR 2.5. However, in the long-term prophylaxis, the major experiences with vitamin K antagonist, although and of course cytoreductive therapy together with the full anticoagulation is the standard of care of MPN patients with VTE. Cytoreduction not recommended if patients have normal blood values. The direct oral anticoagulants are approved for treatment of acute VTE in the general population, but in this population there are currently very limited data. These are just a few series, but you can appreciate are very, very, very small, or patients treated with the DOACs in registries or in retrospective studies. The largest series is this one, recently published by an Italian group in Rome, and they report safety and efficacy in 1 year observation. So DOACs are of interest in MPN, both for prophylaxis and treatment, as we will hear from the presentation from Miriam Kimpton. The prevention of recurrences after VTE is very important because it's an important unmet clinical need in MPN. And so innovative strategies are needed, and DOACs can represent a suitable alternative. As I said, the vitamin K antagonists are effective, but still the recurrences and the bleeding complication are higher in MPN patients compared to non-MPN patients. So DOACs may improve the bleeding risk in comparison to vitamin K antagonist. And with that, I am very pleased to give the mic to Miriam Kimpton that will present her projects on thromboprophylaxis in these patients.
Perfect. Thank you very much.
Thank you, Dr. Falanga. That was amazing, really comprehensive overview. So we'll, as I said before, we'll keep the questions later. I'm now going to introduce Dr. Miriam Kimpton for our next talk. Dr. Kimpton completed her hematology training at the University of Toronto and her adult thrombosis medicine fellowship at the University of Ottawa. She's an assistant professor in the Faculty of Medicine at the University of Ottawa and currently works as a thrombosis physician in the Division of Hematology at the Ottawa Hospital. She's also an associate scientist with the Ottawa Hospital Research Institute, where she's developing a research program looking at the thromboprophylaxis of patients with JAK2 positive MPNs. She's presented a lot of her original work at ASH and ISTH, and she's had numerous publications in this area. She has previously served as the Training Council Chair for CanVector, and she is the recipient of the CanVector Pilot Trial Award for her airport MPN study, which we'll hear a little bit about today. So Dr. Kimpton, thank you very much and for sharing your research with us today.
Thank you very much for this introduction, Dr. Lee and Dr. Falanga. So I believe just having a little difficulty moving the slides forward. We can go. Okay, thank you. So I will be presenting on thrombosis and thromboprophylaxis in JAK2 positive MPN patients today. If we can go forward. Okay, I have no conflict of interest to disclose. The objectives today will be to review the role of the JAK2 mutation in the formation of thrombosis in these patients, the evidence of aspirin thromboprophylaxis in MPN patients, the rates of thrombosis and bleeding on aspirin in JAK2 positive MPN patients, as well as what we know of DOACs in other patient populations and how that could be applied to this patient population, and finally to review the current thromboprophylaxis strategies. Trials that are ongoing in MPN patients. So as we've heard, the myeloproliferative neoplasms are classically defined as polycythemia vera, essential thrombocythemia, and primary myelofibrosis, which in itself is also distinguished between prefibrotic, which has a very similar clinical prognosis as essential thrombocythemia, and then overtly fibrosis, which has its own clinical implications, including a lot of cytopenias. The JAK2 mutation is the JAK2 is a tyrosine kinase, leading to intracellular signaling of type 1 cytokine receptors, such as erythropoietin receptor and thrombopoietin receptor. And the JAK2 V61F mutation is a gain of function mutation where it leads to activating of downstream signaling and leading to a proliferation of myeloid cells. We can go forward. Okay, whoop. If we can go one back. Okay, thank you. So the presence of the JAK2 mutation is found in nearly all PV patients and 50 to 60% of ET and PMF patients. Oh, if we can go back one. The JAK2 mutation has been found in the hematological cells of MPN patients, but also endothelial cells. And that was found in very small case series of JAK2 positive PMF patients who had undergone splenectomy. And so 12 out of 18 of these patients were found to have the JAK2 mutation in splenic capillaries and vein. And also from the biopsy of 3 PV patients who had suffered Budd-Chiari syndrome, so from their liver biopsy. So that has led to the hypothesis made by some that there may be a common hematopoietic and endothelial cell progenitor harboring the JAK2 mutation, leading to a hypercoagulable state in this patient population. And it could also explain why these patients are at higher risk of splenic vein thrombosis, for example. So more recently, Guy and al. Showed that the JAK2 mutation in endothelial cells lead to a pro-adhesive phenotype, both in vitro and in vivo, using mouse model. And it was associated with the increased thrombus formation. So this pro-thrombotic phenotype in the endothelium, primarily due to this pro-adhesive phenotype, resulting from higher exposure of P-selectin by endothelial cells due to the Weibel-Palade body degranulation, that increases the interaction between the endothelium, leukocytes, and platelets, as Dr. Falunga has shown to us earlier. The P-selectin also upregulates tissue factor expression on monocytes and concentration of tissue factor at developing thrombus. And the P-selectin dependent thrombus formation pathway leads to a clot that is both platelet rich, but also tissue factor and fibrin rich. And that opens the possibility for different mechanisms of targeting the prevention of clots. So not only a platelet-based, but also potentially a tissue factor-based prevention, such as can be achieved with anticoagulants. So what is the evidence for aspirin thromboprophylaxis in MPN? So as we've heard, low-dose aspirin is recommended for all PV, JAK2 ET, and JAK2 primary myelofibrosis patients by guidelines where there is some evidence. So there's a little bit of evidence in PV, a little bit in ET, or expert recommendations where there's really not a lot of evidence, such as PMF, where it's mostly extrapolated from other disease. So ECLAP was a double-blind, placebo-controlled RCT. It had a planned sample size of 940 patients. Unfortunately, it had to close early recruitment with only 518 PV patients recruited. And we'll see that that is truly a theme in this rare patient population where it is not possible to fully recruit the target number of patients, unfortunately. And so it looked at aspirin versus placebo. And with the limitation in mind that the full sample size was not achieved, it did not show significant reduction, statistically significant reduction in the risk of non-fatal MI, non-fatal stroke, or death from cardiovascular causes, with a relative risk of 0.41. And because it had a dual primary outcome, so the second outcome being non-fatal MI, non-fatal stroke, pulmonary embolism, major venous thrombosis, or death from cardiovascular causes, again, there was no clear statistical significant reduction when taking into account the number of analyses, but the relative risk was still 0.40. A Cochrane meta-analysis was done on the data available in PV patients, which is ECLAP, and another smaller pilot project called GISP, which came out in 1997, and it found a statistically non-significant reduction in mortality from thromboembolic event with ASA in this patient population. For ET, unfortunately, there is no currently randomized controlled trials. And so the recommendations are extrapolated from what we know of PV patients. One systematic review recently done out of McMaster University showed that there was only low quality data regarding antithrombotic therapies in this patient population. Most patients included in the systematic review were receiving low dose aspirin. And with that, they achieved a modest relative risk reduction of 26%, suggesting that the risk of thrombosis remains elevated despite antithrombotic therapy. We tried to look at the rates of thrombosis and bleeding on aspirin, specifically in patients with JAK2 positive MPN. And so we did a systematic review where we looked at MBASE, Medline, and Cochrane Central Registry. With 1,500 citations reviewed, we were able to pull 97 articles for full text review by 2 independent reviewers. And with that, we included 6 studies, 3 in PV and 3 in ET, involving 659 patients with JAK2 positive MPN who were receiving aspirin thromboprophylaxis. The pooled rate of thrombotic event, both arterial and venous, in this population of PV and AT patients with JAK2 positive mutation was 1.8 per 100 patient years. For bleeding in the same population, the bleeding rate was 1 per 100 patient year. And then if we stratified by subgroups, so with the PV patients, just to have a better idea of, there's a lot of heterogeneity there. So for the PV patients, the thrombotic rate was 1.9 per 100 patient years, with a major bleeding rate of 0.5 per 100 patient years. In ET, the thrombotic and bleeding rates was actually closer related. So the thrombotic was 1.7 per 100 patients year compared to 1.3 per 100 patient years. I would like to spend a little bit of time looking at the DOACs in other patient populations and what we know of this strategy. So for Averroes, which compared apixaban to aspirin in patients with atrial fibrillation, this strategy led to a hazard ratio of 0.45. And importantly, there was no statistically significant increase in major bleeding or clinically relevant non-major bleeding between the apixaban and aspirin groups. And if we look at apixaban in long-term VTE, thromboprophylaxis, so 2 doses of apixaban, 5 milligrams BID or 2.5 milligrams BID, were compared to placebo in patients eligible to receive extended anticoagulation for a venous thromboembolic event. Neither dose of apixaban was associated with an increase in the relative risk for major bleeding when compared to placebo. And major bleeding occurred in 0.5% of patients who were receiving placebo compared to 2 patients or 0.2% who were receiving apixaban 2.5. The relative risk for recurrent VTE or death from any cause compared to placebo was 0.33. More recently, the AVERT trial looked at primary thromboprophylaxis with apixaban 2.5 milligrams BID in ambulatory cancer patients receiving chemotherapy who were at intermediate to high risk of thrombosis per the Corona score. MPN patients were excluded from the AVERT trial because they were not part of the cohorts that generated or validated the Corona score. And so from the on-treatment analysis, major bleeding occurred in 2.1% in the apixaban group and 1.1% in the placebo group for a hazard ratio of 1.89, confidence interval of 0.39 to 9.24. looking at low-dose DOAC versus aspirin, specifically for the prevention of arterial events. There are no studies comparing apixaban to aspirin in this case. So we will be looking at trials looking at rivaroxaban. And so the COMPASS trial assigned patients to a 1:1:1 ratio to receive rivaroxaban 2.5 twice daily plus low-dose aspirin, rivaroxaban 5 milligrams twice daily plus an aspirin matched placebo, or aspirin once daily. And so looking at the low dose groups of rivaroxaban 5 milligrams BID compared to aspirin, low dose aspirin, so there was a nearly statistically significant reduction in cardiovascular death, stroke, or MI, with a hazard ratio of 0.9. The major bleeding events per the ISTH definition occurred in more patients in the rivaroxaban 5 milligrams BID group than in the aspirin group, with a hazard ratio of 1.51. If we can go back one slide, please. And one more, I believe it went twice. Yes. And so looking at, thank you, low dose DOAC versus aspirin for the VTE prevention. So here we're able to compare with the Einstein's choice study, rivaroxaban to low dose aspirin for the extended anticoagulation of patients with a diagnosis of VTE. And in patients receiving rivaroxaban 10 milligrams daily, 1.2% suffered recurrent VTE compared to 4.4% of patients assigned to the aspirin arm for a hazard ratio of 0.26. And importantly, there was no statistically significant increase in major bleeding with a hazard ratio of 1.64. Now assessing another therapy or regimen of aspirin and very low dose DOAC. So that is the arm of the 2.5 milligrams BID of rivaroxaban plus aspirin compared to aspirin alone in for arterial events. And so here, looking at the COMPASS trial once more, we see that with this strategy, there is a hazard ratio of 0.76, which is statistically significant for the primary outcome. The combination therapy of very low dose aspirin plus aspirin compared to aspirin was, however, associated with a statistically significant increase in major bleeding per ISTH criteria with a hazard ratio of 1.78. The same strategy was recently evaluated in another patient population of the patients with peripheral artery disease post-revascularization. The primary efficacy outcome of the Voyager PAD trial was acute limb ischemia, major amputation for vascular causes, myocardial infarction, ischemic stroke, or death from any cardiovascular causes. The incidence at 3 years of this primary outcome was 17.3% and 19.9% in the two-studied group for a hazard ratio for the rivaroxaban arm of 0.85. which was statistically significant. And then depending on the bleeding definition used, so whether it's the TIMI or the ISTH, so with the TIMI definition, there was similar bleeding, but with the ISTH definition, significant changes in bleeding was found, so 5.94 compared to 4.6. There's very little known, as we heard, for DOACs for secondary thromboprophylaxis in MPN patients, and I just wanted to spend a little time on one of the studies, which is a case control study of 25 MPN patients that were taken from the Aubin registry, a French registry. And these patients were treated with the DOAC, apixaban or rivaroxaban. 17 of them had ET and 8 had PV. 13 were using a DOAC for atrial fibrillation and 12 for thrombosis, so 8 VTE and 4 stroke. The median follow-up here was 2.1 years. They managed to do a case control study following a one-to-one pattern matching by age, sex, and type of NPN to control for major confounders. So they compared patients using DOAC to the ones receiving aspirin. And what we see is that from the 25 patients in each group, 18 of them had the JAK2 mutation, and one patient in the DOAC group compared to 2 patients in the low-dose aspirin group experienced a thrombotic event. And major hemorrhage was found equally in both groups, so DOAC compared to low-dose aspirin, so 3 events in both groups. So what are the current thromboprophylaxis trials in MPN? The first one I was hoping to talk about was the ARIS trial, which you might have seen the recent publication about. So ARIS trial is a multi-center double-blind trial assessing 3 different aspirin regimen. And recently the dose finding portion of this trial was published in Blood. So ET is associated with increased platelet production, which is thought to lead to aspirin resistance. And aspirin irreversibly inhibits the COX-1, interrupting the biosynthesis of thromboxane A2. In normal individuals, the effect of aspirin is felt over several days, which is the time needed for new platelets to be generated by the megakaryocytes. In ET, however, the effect of aspirin is thought to be blunted because of the increased platelet production. The aim of the ARIS trial was to optimize the platelet COX-1 inhibition as assessed by ex vivo thromboxane B2 production during whole blood clotting, while maintaining COX-2-dependent vascular prostaglandin biosynthesis, which are associated with vasorelaxation and platelet inhibition. 245 ASA-treated patients were enrolled in this dose-finding portion of the study. 60% were JAK2 positive. It was a very pragmatic study where anybody who was already on aspirin were able to participate. Interestingly, though, a third were IPSET score low, so 0 to 1. So it's perhaps not always needing aspirin thromboprophylaxis. And so after 2 weeks, ASA twice or thrice daily was found to significantly reduce inter-individual variability in serum thromboxane B2 compared to the once daily arm. And the urine prostacyclin metabolite was similar in the 3 arms, leading the researchers to think that the vasoprotective aspect was not harmed with this strategy. They did find, however, that more GI discomfort was noted in the 3 times daily arm. And so going forward with this dose-finding study, the long-term ARIS trial will be comparing aspirin daily to aspirin twice daily. The questions remaining to be answered with this more long-term trial and other studies is, does the improved inhibition of thromboxane synthesis lead to improved clinical outcomes, as this is a surrogate marker? And is this increased aspirin dose associated with heightened risk of bleeding? So I think the results of this trial, the ARIS long-term trial, will be very interesting. And now I would like to take a few minutes to talk about the airport MPN trial, which is a pilot randomized controlled trial of apixaban for the thromboprophylaxis of JAK2 positive myeloproliferative neoplasms. And it has been funded in part by CanVector. So the study aims to assess the feasibility of a randomized controlled trial. If we could go back, thank you. Comparing apixaban 2.5 milligrams twice daily to aspirin 81 milligram daily in combination with standard cytoreductive strategies to prevent thromboembolic complication in JAK2 positive MPN patients who are eligible to take either aspirin or apixaban. We hypothesized that apixaban at a dose of 2.5 BID will be superior to the current intervention of low-dose aspirin in preventing arterial and VTE complications in this patient population. And based on the data that are previously presented, we expect a risk reduction for venous events of 70%, a risk reduction for arterial events of 10%, so an overall risk reduction of about a third. It will be a multi-center, or it is a multi-center prospective open label blinded endpoint randomized controlled trial. 4 sites have been chosen, and these sites are meant to represent different type of clinical sites where JAK2-MPN patients are followed. And so, like I said previously, one of the biggest challenge in studying this patient population, this rare patient population, is to both identify and recruit these patients. And so far, none of the trials assessing thromboprophylaxis or thrombotic events were able to meet their target sample size. And so with 6 months of recruitment, patient would be during that recruitment process, patient would be randomized to either apixaban 2.5 BID or aspirin once daily. And they would be followed for 6 months. And our primary feasibility outcome would be the number of participants recruiting during a 6-month period at the 4 different participating sites. The secondary feasibility outcomes would be the proportion of screened patients meeting eligibility criteria, the consent rates, the reason for non-consents, adherence to therapy, and the proportion of patients picking up medications at 3 and 6 months. For efficacy and safety outcomes, so the primary safety outcome would be symptomatic, objectively confirmed arterial or venous thromboembolic disease or death related to thromboembolic events. And our safety outcome would be major bleeding and clinically relevant non-major bleeding as defined by ISTH. We are hoping to recruit 22 patients per arm. This would be a rate of about 7.5 patients per month. We plan a time to event analysis for the full-size trial, and so this pilot project will inform recruitment rates and expected rates of thrombotic complications, which will help to better define the target sample size for the full-size trial. We're hoping to also gather some data on the variance and precision of the rate of thrombotic event in this patient population. So far, despite all the challenges with COVID, we were able to open the trial in Ottawa, and we've screened 3 patients and 1 is to be enrolled. And the next steps will be to open the recruitment at our other sites. You probably have heard also of the associated study, which is a Delphi process and practice survey of hematologists and thrombosis experts on the prevention and management of thrombotic complications in JAK2 positive myeloproliferative neoplasm patients. And I would like to thank everyone who have participated through CanVector in this survey. And finally, if the pilot project is shown to be feasible, then our goal would be to move on to a full-size RCT evaluating efficacy and safety of apixaban in this patient population. I'd like to thank my co-principal investigator, Dr. Aurélien Deluc, on the airport trial, as well as my mentor, Dr. Marc Carrier, and also the co-investigators of the airport trial, so Pierre Villeneuve, Leslie Skeeth, Sonia Sarkozy, and Linda Lacroix. So thank you very much. I'd be happy to take any questions.
Thank you very much, Dr. Kimpton. That was really a thorough overview of the evidence, or really, you know, a lot of the work that we still need to do. We have a few questions coming up, and we have about 10 minutes or so to address them. So maybe I can open this question to both of you. The question is about in a patient who develops unusual site thrombosis and is found to have a JAK2 mutation, but the CBC is normal. Would you start cytoreduction for secondary thromboprophylaxis, assuming that this is, you know, an MPN? And if so, what sort of hydroxyurea dosing do you suggest? And again, assuming this is a patient with a normal CBC, the hematocrit is less than 42%. So, you know, not meeting the usual criteria for an MPN. Dr. Falanga, you're muted.
Okay.
To hear from your experience. I'm sure you have in many of these patients? What do you do?
Yes, we do not give any cytoreduction in these patients. And this is our daily practice. This is also, I mentioned that in the recommendation that I reported in the slides, because there is the reduction of the blood cell count is important to reduce the risk of thrombosis, but if the number is okay, I mean, there is no reason why we should give on the top of anticoagulation also cytoreductive agents. So we usually do not use that. Also, if a JAK2 mutation is present in, for instance, essential thrombocythemia patients, we do not start with the cytoreduction.
I see. And then
I'm sorry, you cut off.
oh, sorry, Dr. Kimpton, anything to add there? What's the practice in Ottawa?
My understanding is the practice is similar, so I do not have anything to add.
No, and maybe I can just add quickly then. Presumably, we certainly do this now fairly routinely in patients who are presenting with unusual site thrombosis, especially, visceral vein, splanchnic vein thrombosis. Even when they have a normal CBC, we will now check for their JAK2 mutation. Is that pretty standard practice for you as well now?
For me, yes, I do that. It's a standard practice. But this will not, will not lead me to the decision of using cytoreductive treatment if the blood counts are normal. So it's just to classify the risk of thrombosis in these patients and for long-term follow-up of the patients. But if the cell count is fine, we do not start cytoreduction.
Okay, so on that, so it sounds like then management for the patient would not change. You would anticoagulate the patient as you normally would.
Yes.
The JAK2 is really for prognosis and follow-up long-term.
Yes, and in case things will be changing because in follow-up the disease may have a different presentation or different stage, then we decide by time to time with the individualized treatment.
Thank you. Dr. Kim?
Yeah, I think it can be used also to decide on the duration of treatment. So there's not a lot of data, but MPN patients, even with good counts, so the ones that are cytoreductive are still at higher risk of recurrence. And so just the count themselves are sometimes not enough of an indication to know whether you should discontinue or not anticoagulation for secondary thromboprophylaxis. So I think having that extra knowledge of the mutation status of the patient could be helpful with the discussion of duration itself.
Yes, definitely. I agree with that. In this case, the patient is considered at high risk, and the prolonged anticoagulation is decided.
That's great. So a follow-up question then. So for this patient who has an unusual site, say splanchnic vein thrombosis, normal CBC, say they are positive for JAK2 mutation, would you actually treat these patients with both anticoagulation and aspirin, or just anticoagulation as well?
Personally, I would choose just, oh, sorry, go ahead.
No, please go ahead.
Okay, so I would choose only anticoagulation. I think they're also at high risk of bleeding, and so so a patient with a normal CBC, JAK2 positive, splanchnic vein thrombosis, normally I would, especially if this is a first event, like we had talked about, doing aggressive cardiovascular risk reduction and then using an anticoagulant would be my preference.
Yeah. I perfectly agree.
Okay, so again, just to summarize, and really no change in management is standard anticoagulation, right? And so not addition of aspirin. And I assume then standard anticoagulation, you would consider using a DOAC in this person. has JAK2.
Of course, we are talking about a venous thromboembolism in this case.
Right. Yes.
Because
Yeah.
could be different for arterial thrombosis.
Right. I assume if it's arterial thrombosis, you would add aspirin to.
Yes, there are specific situations in which, with the help of the cardiologist or neurologist, it depends the type of arterial thrombosis. Then we collaborate in the treatment of these patients.
Perfect. Thank you. And other question we have. So, Dr. Falanga, you mentioned that you suggested anticoagulation in a patient with MF or ET who has a history of venous thrombosis in the past. So say this is a patient who had thrombosis 15 years ago. All right. Now they are diagnosed with MF. All right. Would you put them on anticoagulation now if the patient hasn't been on anticoagulation before and they, had this remote thrombotic event and stopped anticoagulant therapy, did not have a recurrent thrombosis, but now has a new diagnosis of, say, MF or ET?
No. If the history of thrombosis, I didn't mean to suggest a full dose anticoagulation for treatment. That is a suggestion given by those recent guidance released by the group of experts as far as prophylaxis, not treatment. Of course, if one has had a venous thromboembolism thromboembolic event 15 years ago, you do not start full anticoagulation now.
All right, but you need aspirin thromboprophylaxis.
Yes, you can consider thromboprophylaxis, considering the risk level of the patient, considering if there are other cardiovascular risk factors, and tailor the anticoagulant prophylaxis accordingly.
Thank you. Dr. Kimpton, so I have a question.
Yes.
For your airport study, was there any particular rationale that you chose apixaban twice daily versus other DOACs, say specifically, dabigatran, or, just from a mechanistic point of view, or this was just the DOAC of convenience, or somehow the twice daily regimen is more, perhaps potentially more efficacious, just looking at the data, looking at twice daily aspirin, for example?
It was looking mostly at the previous studies where we felt comfortable from the safety aspect as well, from the apixaban, so either compared to placebo. Unfortunately, like I said, there's not a lot of data for apixaban compared to aspirin. And so it was mostly based on a safety aspect. So whether that's true or not compared to rivaroxaban 10 milligrams once a day, or even the newer regimen of 2.5 milligrams twice daily, that I don't know because it has not been compared head to head. But the thought was mostly of a safety point of view. So decreased bleeding, or at least similar bleeding to placebo from for example, on treatment analysis of the AVERT trial.
Great, thank you. So I'm going to push both of you a little bit in terms of novel therapies in this area. Obviously, we actually still need more evidence, even just for traditional therapies like aspirin and now really DOACs, for example. Are you aware of, or do you think we should be looking at newer agents like P-selectin inhibitors? Dr. Falanga, you mentioned that this is potentially a very critical mechanism for thrombosis, and perhaps these patients would not be associated with a higher risk of bleeding.
Yes, I think this is a very interesting area to explore, and more research should be done in that area, of course, because this type of patients and this thrombosis, this complication, thrombotic complication associated to MPN, are still a very unique situation. And we do not have a complete answer. So just to start with the studies like Miriam Kimpton has presented is already an important step forward, trying to understand the prophylaxis with the DOACs. But of course, also newer agent, maybe even more promising, but they are to be tested, and a lot of work is needed in this area.
Thank you. Dr. Kimpton? Are
Yes,
you
I can.
any other, because you reviewed the evidence, are you aware of any sort of trials or preliminary data in sort of non-anticoagulant agents?
So I agree that doing a P-selectin inhibitor like crenilizumab in this patient population would be very, very exciting, actually, especially since it seems to target the major mechanism of thrombosis in JAK2-positive MPN patients. Another mechanism that was recently looked at is with ruxolitinib, for example, which is a JAK2 inhibitor as well. So there is a little bit of data that it seems to decrease the risk of thrombosis, but it's always kind of balancing the side effects of these medication, the cost of this medication as well. So I'm not sure that it will ever replace something like as easy to take as aspirin or even perhaps a low-dose anticoagulant, but going for medications that are much more targeted, such as a JAK inhibitor or a P-selectin inhibitor, would be very, very exciting.
Yes, thank you. I certainly agree with you that, perhaps we should look into using our traditional agents in the best way possible, but certainly because the cost of new medications is becoming, an increasing problem for many of us. And so it's 10:30. I want to thank both of you for outstanding overviews of the evidence available. This is, becoming a more and more interesting area, particularly as we're understanding the mechanisms and potentially have more agents. I want to thank everybody for joining us today. And I just want to let you know the next seminar will be in April. Please complete the evaluation for the seminar, because this is important for the MOCAP points. We are looking forward to having you back. Thank you again, everybody, for joining us. And again, these seminars are recorded, so if you like to go back, there was just tremendous information on, in both of these talks. So again, thank you, Dr. Falanga, Dr. Kimpton.
Thank you. Bye-bye.
Yes, thank you.
Thank you.
I look forward to seeing you again, Anna, in April.
Yes, very shortly. Thank you.
Yes. Thank you, everyone. Bye-bye.
Thank you.
Goodbye.
Bye-bye, Miriam. Was very nice. I enjoyed your talk.
Likewise. Thank you so much. Bye-bye.